that says lecture three, even though this is not our third lecture. That's just the PowerPoint we're going to be working on today. So it says, if I can pull mine up, it says Ophthalmology Lecture 3 by me, Tyler Hines. And the first slide is a whole bunch of topic slide, kind of like an index, and then getting into superficial eye disorders as our first topic. And we're going to be doing this lecture set for both today and Thursday because it's a little bit of a dense material. So we're going to be doing that for both days for this week. So if anyone had any questions, feel free to pop on and ask or throw them in the chat. I'm going to throw my email in here again in case anyone needs it, or if you have any questions or things you want to ask or clarify or go over, feel free to email me at any time. That's my personal email. I check that one a little more frequently, but you could have the Toro one as well. Okay. So feel free to email anytime you need. And sorry, I was just shutting the door. So let's get going. Okay. So can everyone see my screen, what I'm presenting? Okay. Good. Thank you. Okay. So we're going over ophthalmology. It says lecture three, but of course, this is our second lecture. So getting into it. So, of course, this is all the topics that we're going to cover throughout this lecture series. So, getting started, we have our superficial eye disorders. So, our conjunctival disorders. Remember, the conjunctiva is our thin layer of transparent skin over the eye and inside of the eyelids. So, our conjunctival disorders, we have pinguecula and pterygium. And our corneal disorders known as arcus senellus. So, conjunctival growths. Of course, these are going to be more common among older people. As you age, you start to develop more things. And the reason that it's more common in the elderly is because it's most likely, we're not positive, but we're pretty sure that it's a result of long-term UV radiation. So, sun exposure. So one of the best ways to prevent these conditions that we're going to go over, including pinguecula, pterygium, and arcus, are all to be wearing your sunglasses when you're driving, when you're out in the sun, playing sports, etc. If you're going to be in the sun for an extended period of time, you should consider wearing sunglasses because the sun will start to damage the surface of your eye. Now, pinguecula is a raised yellowish white growth next to but not overlapping the cornea. So if you remember last time we had talked about the limbal margin, remember the limbus is between the sclera and the cornea. It's kind of that intermediate zone right as the cornea is starting. So it's only going to go up to that limbal margin, but it's not going to go onto the cornea. Remember the cornea is our clear dome shape over the front of the eye. Usually, it doesn't cause any significant problems. A lot of times, the patients don't even realize that they have it because they could be pretty small. Sometimes they're kind of big. Sometimes they even look like a little bit of a plaque underneath the conjunctiva. So sometimes, if it gets to be too big, it can become a little bit irritating. Of course, you could have it both sides because nature loves symmetry. So bilateral is often how you'll see these, but no treatments needed. It's just kind of like a callus, if you will, which is what I tell my patients in the clinic. Nothing to worry about, nothing to do, as long as it's not bothering them. And usually it does not bother them, and we just leave it alone. It's just like a little callus. Pterygium, that one you could say the terror, the terrible. So the PT sound and the terror, T and T. So that's a fleshy growth that starts in the conjunctiva, but it goes on to the cornea. So that's going to be the difference between the pinguecula and the pterygium. The way that they are described sometimes may be similar, a fleshy, yellowish, whitish kind of growth, but the distinction is where they are. So the pinguecula, remember, will never be on the cornea. Pterygium does extend onto the cornea. So once it starts extending on the cornea, that's when we start to say it is a pterygium. So it can distort the shape of the cornea. Remember, the shape of the cornea has a lot to do with our astigmatism and the blurring effect of our vision. So if it grows onto the cornea and distorts the shape, it may induce more astigmatism. And of course, it can go right into the center of vision, right in your visual axis over the front of the pupil. And then, of course, we're going to need surgery to remove the pterygium because it's going to be visually impairing if it's in their visual axis. So again, these two things, nothing really crazy about them. They can start from sun exposure. They may be irritating if the growth is significant, both of them. They're a little bit unsightly, but again, pinguecula, no need for a treatment. Pterygium, you're going to need surgery if it starts to impede your vision. And here's some picture examples of both. So again, remember, here's our pinguecula not extending onto the cornea because it's stopping at the limbus margin here, which is what I'm tracing with my cursor. And you can see in the cartoon down here as well, it's not going past that black margin, which is the limbus there. The pterygium is going on to the cornea, and you can see here this one is starting to reach into their center of vision, in their visual axis. So it's going in front of the pupil, which means it's going to be blocking some of their vision. So it's something that you need to address to give them that vision back. Arcus. So corneal arcus, arcus adiposus, arcus juvenalis, arcus sinalis, all the same thing. We just say arcus in the clinic. It's an asymmetric bilateral white stromal deposit at the edge of the cornea. Really, that's just a lot of words just to say it's a white ring, doesn't do anything to the cornea, doesn't impede their vision. Usually it will start to thicken in terms of the density, but it's not changing the shape of the cornea. It's not affecting their vision. This says over 80 years. That's kind of the textbook definition, but I have seen it in younger populations, even in the upper 50s, low 60s. Usually it starts inferiorly, but again, it'll be very opaque at the start. It'll be very light, very hard to see, easy to miss. So again, it does not affect the vision and there's no treatment necessary. Excuse me for 1 second. I just got to open the door for my dog. Sorry about that. He got trapped in here. Okay, so moving on to our ophthalmic infections. So we're going to cover a bunch of infections in this section. We have viral, fungal, protozoal, and AIDS-related eye disorders, with, of course, subsections within each that we'll go over. So, herpes zoster, shingles, ophthalmicus. This is, of course, because of the varicella virus, which we know is chickenpox. I'm sure you guys have gone over that before. The virus may remain dormant in the dorsal root ganglion for years to decades. So even people that have never had herpes in the past, herpes ophthalmicus, if they've had chickenpox in the past, that does put them at a risk for this infection. So it's something that you always have to watch out for because anyone who's had the virus, it's remaining dormant in their body and stressors, like just life stresses, bodily stresses, injury, sickness, all of these things can reactivate that virus and cause it to flare back up. It's going to be a vesicular rash. It's going to involve, of course, the surrounding skin and eye structures along the trigeminal distribution. It does not cross the midline, but it can go up until the tip of the nose. And that's one of the biggest signs there. That's the Hutchinson sign. So, this is severe or recurrent episodes. They can be associated with glaucoma, scarring, and cataract formation if they continue to recur. So again, as I just said, the Hutchinson sign is when the lesions are at the tip, side, or root of the nose. So anytime this is going along the trigeminal nerve and then ending around the nose, that's a strong predictor of an ocular involvement. So you should be consulting somebody from your ophthalmology team, whether that be a clinic nearby, someone on call at the hospital, but you should be getting in touch with someone in ophtho to start to evaluate this. And then, of course, we're innervated by the nasociliary nerve, which is the branch off of the ophthalmic branch, the V1 of the cranial nerve 5. So under 50 and immunosuppressed or HIV positive. So again, you're not going to see it under 50 unless they have a suppressed immune system or HIV. It's also going to be very common in females from the 70s to the 90s. And again, anyone with immunosuppressive disease or systemic disease is going to be at risk. So following up again with our herpes, our signs and symptoms, it's going to be an influenza-like illness. They're going to complain of fatigue, malaise, some fever, may last for up to a week before the rash even starts. They may have paresthesias or pain prior to the rash occurring. And of course, they might have that unilateral, so only one side of the face, vesicular rash over the forehead, eye, eyelid, and nose. You may notice some areas of the face that have some redness, some swelling, some pain, some sensitivity to the light, blurred vision, some petechial hemorrhages, of course, on the skin, also in the eye, your follicular or papillary hypertrophy. You're going to have a swollen preauricular node. The big thing, and I'll show you a picture of this in a second, the big thing that we're looking for in the ophtho world is going to be our dendritic lesions. Now, these are bad news for the patient, but I'll tell you honestly, they do look kind of pretty from our perspective. Now, of course, like we mentioned, continued infections, repeat infections of the herpes virus can cause bouts of glaucoma, iritis, uveitis, nerve palsies, all their secondary infections. It can affect the optic nerve, the retina, and of course, they can have that post-herpetic neuralgia, so pain even after it looks like things have subsided. And you can always, of course, treat with things like gabapentin, pregabalin, things like that that are going to help alleviate that neurologic pain. Corneal lesions are usually going to occur a few days after the rash. So again, call someone from ophtho. You can try and help alleviate their pain and their irritation by giving them some cool compresses. Some people like warm compresses better. It's more so patient specific. It's not going to hurt them either way, but a lot of times cool compresses are a little bit better in terms of pain relief. You can give them pain relief drops. You can give them pain relief over-the-counter pills, acetaminophen, your Tylenol, ibuprofen, etc. You want to make sure the eyes are always lubricated. Dry eye is much more of a common problem than people really realize. And we'll get into dry eye in one of our other lectures, but throughout this whole series of ophthalmology, throughout this whole course, remember dryness is actually something that not a lot of people talk about, but actually is at the basis of a lot of ophthalmology complaints. It's just that dry surface of the eye. You may need antibiotic drops if there's a secondary type of infection, of course, being bacterial. But if you suspect that there's a secondary infection, give them the antibiotic drops that are going to cover for that infection that you're suspecting. Antiviral medications, acyclovir, IV therapy. Sometimes we do just Valtrex pills, by mouth for, 7 to 10 days, like 3 grams or so per day. So we'll usually do 1 gram pills 3 times a day for like 10 days. But IV, of course, is always great if you can. Herpes zoster infections, like we had said, are always prone to recur. So always keep that in the back of your mind. Someone who's had chickenpox when they were younger, or they've had confirmed herpes in the past, it's always a possibility that it can pop up in them at any point in their life. So we have herpes simplex 1 and 2. Typically, these are unilateral, self-limiting. It'll go away on its own within a few days or weeks. 25% of them will have a recurrence of the infection within 2 years, though. So again, keeping in mind your patients as you get to know them, especially if you're in more the primary care setting, keep in mind, what your patient's histories and normals are. Of course, after a week of constitutional symptoms, you'll start to get some inflammation, maybe some corneal ulcerations. Again, that dendritic lesion that we'll see in a second. They may be light sensitive, and of course, the vesicles across the skin. Type 1's typically not contagious, but of course, you never want to be ruling out a contagious aspect of these viruses. So anytime you're evaluating them, make sure you're cleaning all your equipment, make sure you're not having any contamination to other patients, make sure you're always washing your hands, etc. Now, here is that dendritic lesion that we were talking about. So when you add a little bit of fluorescein, it's a dye, like a yellow dye, And when you add the woods lamp, like we talked about last lecture, or if you use a cobalt blue light on your on your slit lamp, you're going to see that dye start to fluoresce and light up in the cornea. And when you see it kind of look like a branching pattern like this, like lightning bolts or branches, that's our diagnostic, or that's diagnostic usually for herpes. You're not going to see that with anything else. Of course, we could always do a corneal scraping or a viral culture, but again, most of this is going to be history, like we talked about last time. You want to really always make sure you get a good history for all your patients, and then, of course, making sure that you're doing the appropriate diagnostic tests. And a fluorescein exam here on the anterior part of the eye, that's, of course, the test that you're really going to need to check out for. HSV1 is more common in adults. HSV2 is more so neonatal and oftentimes a little more diffuse across the face as well. So it's not just usually in one eye area with the HSV2. So a little bit more here about the herpes simplex 1 and 2. The treatment, of course, is going to depend on the severity. If there's not too much involvement of any other body systems, if it's just the face, just the skin, it's not really as important as if it's going on to the eye. If you have eye involvement and you have those corneal ulcerations, that's more so emergent. You really need to keep that in mind that you need treatment soon because the longer those ulcers last, the more chance that there's going to be scarring in that stroma. Remember, we talked about the epithelium is the outermost layer. The stroma is more the body of the cornea. And when ulcers or cuts or lacerations extend into that stromal layer, you're going to start to get scarring. And if it's in their visual axis right in front of the pupil, they're going to have permanent vision loss. So it's something you really want to make sure you get ahead of and treat early. Now, of course, we're going to do maybe some topical antiviral drops. We could always do some oral antiviral medication. Like I said, PO Valtrex. We usually do 1 gram pills 3 times a day for like 10 days. You could, of course, do some corneal scraping to get some of those diseased cells away and try and scrape off some of the virus that's in there. And of course, if it's a severe or recurrent infection, we may have permanent corneal scarring, like I just mentioned. You may need a corneal transplant to get past that. Steroid use, and this is very, very important. You guys should know this. Put a star here. If you're not listening, listen in now. Steroid use is contraindicated when they have herpes. So do not give them steroids, especially steroid drops, until we treat the herpes. Because if you give them steroids, it's going to feed the virus and it's going to flare it up, it's going to rev it up, it's going to make it way worse, and it's going to add to that scarring and that ulceration on the surface of their eye. So do not give steroids. Steroid use is contraindicated in our herpes patients until the herpes is being treated adequately. Now, sometimes we can have patients that are having a lot of systemic inflammation secondary to this type of virus. And we can give oral steroids later on to help quell that inflammation. But again, we need to get the herpes under control first. So unless you're ophthalmology and taking head of it, don't worry about, what I just said there about giving the steroids later on. You really just want to remember steroid use for herpes virus patients contraindicated. Do not give steroids because it will make it worse. Okay, now moving on to our fungal eye infections. So, Fucifarium is found in plant material, plant soil, it can cause serious eye problems and, of course, blindness. Again, remember, all of these conditions can cause blindness. If it starts to ulcerate, if it gets a really bad infection, if it goes through the stroma, if it perforates the eye, you start to have a leak. Those are all serious things that can develop from any type of infection, whether it's fungal, viral, bacterial. It can eat away at the eye, and the longer it's left untreated, the more damage is done. And the more damage is done, the less we can do about avoiding the vision loss. So at some point, if you let it go long enough, vision loss is going to be inevitable. Now, our big risk factors for the fusarium are going to be our contact wearers. We have to make sure that we're exercising good hygiene with our contacts. Now, everybody here knows someone who doesn't wear their contacts correctly. Maybe it's you. And you want to make sure that you really start to listen to the directions. If you have dailies, don't sleep in them. Don't wear them multiple days in a row. Don't swim in them. Those are the kinds of things you want to watch out for, in your patients if they're incorrectly using their contacts, if they're not cleaning them correctly. Say for example, they're multi-day, multi-week use ones. You want to make sure you're cleaning adequately using new solution every day. And make sure it's designated contact lens solution, not just tap water, because tap water is where you're going to start to find all of your bacteria or your funguses, or someone who didn't clean their hands correctly. They may have this Fusarium fungus on their hands. You never know where people have been, what they're doing, what you're doing. You might not even realize what you've touched. So remember, whenever you're wearing contacts, exercise proper hygiene. Take them out when you're supposed to. Don't sleep in them. And if they are ones that you can rewear, make sure you're washing them appropriately with brand new solution every single time. Your signs and symptoms, just like all of your eye things, you're going to have blurry vision, pain, redness, increased sensitivity to light, and excessive discharge from the eye. So that's one of the big things with fusiformia. And it's typically going to grow whenever you have a tear on the surface of the cornea. So again, that epithelial layer, that's our most commonly damaged area. Whenever you have a tear on the surface, that's where infections are going to start to set in. And that's why contact lens wearers are at an increased risk because they oftentimes scratch their cornea very slightly, but it is an opportunistic infection that could set in as soon as you scratch that cornea. And again, this fusiform, if it penetrates the eye into the cornea, the back of the cornea and the anterior chamber, it can cause permanent loss of sight. So, of course, we could always do our corneal scraping, biopsy, but again, history is going to be the big thing here. You always want to make sure you get a good history. And of course, you could do antifungal drops. They should be started ASAP to prevent scarring or blindness. Drops may be necessary for 2 to 3 months, though. So, fungal infections in ophthalmology, very, very rare. We don't see it very often. Now, I currently live in a rural part of Virginia, more of a farm town, and even though there's a lot more farming and soil and plant material here, even my supervising physicians, one of them has been around in this area for over 40 years. He said he hasn't seen it yet. So that was one of them. The other supervising physician that I work with, we had one patient that we suspect was a fungal infection. It was a very weird presentation, and he wasn't responding to what we originally thought it was, which was bacterial treatments and antibiotic drops, which is what led us to start to go down the fungal route. And eventually we consulted with a cornea specialist, and between the two of us, we got it under control. And we did add a bunch of antifungal drops, but those types of drops have to be used like every 2 hours for weeks or again, months at a time, depending how bad it is. But it is very rare, so you probably won't see this, but it's something to always keep in mind, especially if you're in an area where they're using a lot more soil and planting and things like that, like I am here in a rural area. But it could even happen from, just cutting the grass, for example. That's still plant material, dirt, soil, dust flying up in the air. So you don't have to be in a farming community to find those fungal infections. It could even just be cutting the grass. So again, very rare, but something to keep in mind. Now, our protozoal eye infections, acanthamoeba keratitis. So, the microscopic amoeba commonly found in the environment, usually entering through a cut or a wound or through the nostrils. Again, any cuts on the surface of the eye, this is going to be opportunistic and it's going to leach itself into that scrape on the epithelium and start to proliferate. But once it is in your body through any type of thing, again, the cuts, the wound, the nostrils, it can travel through the lungs, through the bloodstream, other parts of the body, especially to the central nervous system. And it's usually going to be from contaminated water. So our at-risk populations are going to be our immunocompromised patients, again, our chronically ill patients, and then again, contact lens wearers. And this, especially this acanthamoeba keratitis, this is big with your contact lens wearers if they're doing things incorrectly with their contacts. Again, remember, you don't want to be using tap water to clean your contacts out. You don't want to be swimming in them because, again, you're going in a lake, a pond, a ocean, a public pool, whatever it may be. There's bacteria in there, whatever type of bacteria it may be. And then, of course, you have your little protozoal amoebas in there that you just don't know about, you don't see. But if you're wearing your contacts when you're swimming, you're going in these dirty environments, you're not wearing them properly, you're not cleaning them properly. That's the people who are going to be at most risk for these acanthamoeba infections. So again, prevention is going to be hygiene, hygiene, hygiene. Make sure you're using your contacts correctly. And of course, remember to try and keep your immune system up and running as best as you can. And always keep it in mind with your AIDS patients, your immunocompromised patients, that this is, again, an opportunistic infection, this little amoeba, and it could always be an infection for them to keep in mind. So here's one of the earlier stages of acanthamoeba. I have a picture on the next slide that's going to be a lot more detrimental. But again, your acanthamoeba, your signs and symptoms, these are going to be your basic signs and symptoms for everything with your eye condition. So again, I can't stress it enough. Your biggest things are going to be your history. That's how you're really going to get most of your information that you need. So your signs and symptoms, sensitivity to light, excessive tearing, blurry vision, eye redness. One of the big things with acanthamoeba, though, is pain out of proportion to findings. So they're going to be in a lot of pain, despite not seeing anything too off with them in the early stages. They may have a foreign body sensation and, of course, ulceration. Now, the big thing with acanthamoeba, one of your buzzwords that you guys need to listen to right now, if you're not listening, listen now, is going to be your ring-like ulcerations and your stromal deposits. That's the big things that they talk about with acanthamoeba keratitis. Your ring-like ulcerations and your stromal deposits. Diagnosis, we can always, of course, do a corneal scraping. Treatment is a little more difficult due to the organism's ability to encysst itself. Many of these cases are going to result in permanent vision loss. It's really hard to treat these things. We can give them a combination of antimicrobials, corneal debridement, again, try and scrape out those diseased cells, try and scrape off the plaques of the amoebas. And of course, the drops that we are going to be using may be used every single hour, and we're going to be using it for weeks at a time. The CDC even says that sometimes, or oftentimes, corneal transplants are going to be needed to recover that lost vision because, again, this acanthamoeba is so difficult to treat that it's just going to tear up the cornea. It's going to insist. It's going to deposit in the stroma, which, again, is the body of the cornea, the thickest part of the cornea. And once it starts getting so deep and insisted, we just can't do anything about it sometimes. And this is such an easy thing to catch, again, if you're using your contacts incorrectly. So here's more diffuse deposits, and of course, a much worse infection of that acanthamoeba keratitis. Now you can see this bubble here. This is actually a deep ulcer. This is actually looking like it's penetrating through the cornea. This person, they're not seeing out of this eye anymore. This infection is just way too bad. They may be able to get a corneal transplant and try and help fix this, but again, it depends how deep that infection went. If it went into the anterior chamber and the more posterior parts of the eye, sometimes there's just nothing that we can do. So again, the biggest thing with the acanthamoeba keratitis, like I said on the last slide, he put a star right here, a ring-like ulceration, and of course your stromal deposits. So if you find a patient on your rotations or on your pants or anything like that, some of the tests that you may take, your EORs, your ER rotation, for example, if you find that you're talking about a patient that's using tap water or dirty water for their contact solution, not wearing their contacts correctly, think acanthamoeba. Am I going too fast for anyone, or is this an okay pace? Thank you for answering. Okay. So you just take a drink of water and then we'll keep going. Okay. Moving on. So now we're getting into our AIDS-related eye disorders like our Kaposi's or molluscum, and of course some of the internal eye manifestations that we may see. So Kaposi's sarcoma. This is the most common anterior lesion with AIDS. It's a malignancy of the eyelids or the conjunctiva. It's a violet colored flat or nodular growth. You're going to see a big bucking bump like this. Again, violet colored there. So you see that deep purple color. Our goal of the therapy is to relieve our ocular irritation, the mass effect, and disfigurement. So, of course, remember, mass effect can happen with any type of lesion on the body. If it has mass to it, if it has size, it's going to start pressing on different things in the body. This one specifically here, this is going to have a mass effect for both the eyeball and the eyelid. So your eyelids are not going to have proper closure if you have this big honkin' nodule here. And of course, this mass effect can be pushing back onto the eye as well, maybe even causing some irregular astigmatism with the cornea because of the weight of that nodule. So again, our goal is just to relieve the ocular irritation, get rid of that mass effect, and of course, make it look like they're not so disfigured because these can become proliferative, they can become very big. But this is pathognomic for AIDS. So again, if you're talking about a patient with AIDS, and they start to have that violet color, big nodular growth, that's our Kaposi sarcoma. Conversely, if you don't get a good history from someone and you still see this and it doesn't talk about AIDS, and you see that they have this big violet colored growth, you should start thinking about AIDS, even if they didn't have that in their history that they stated to you. So again, this Kaposi sarcoma, this is an important point. I want everyone to listen. The Kaposi sarcoma, the big violet nodular growth, it could be flat, could be nodular. If they have this big growth on the eyelids or the conjunctiva, that growth means that they are an AIDS patient. And if they are an AIDS patient without it, keep looking out for it. Okay, now moving on, we have molluscum contagiosum. You've talked about this in other classes. I know we've definitely talked about it in derm. I don't know where you guys are yet, if you've finished derm or not, but molluscum contagiosum, nonetheless, small flesh-colored umbilicated nodular growth. That's going to be the big thing, is this umbilicated word. You're not going to see this with really anything else except for the molluscum. So that little central divot there, that's the umbilication. That's pretty much always going to mean molluscum. These are viral, they tend to spread around, they can be contagious to other people. So you, of course, want to make sure you're getting this under control as quick as you can. Larger, more numerous growths, again, they can be bilateral, and of course, they can cause eye irritation. So if they're located at the edge of the eyelid, again, mass effect, just like we talked about on the last slide, being on the edge of the eyelid, that can cause irritation to the surface of the eye, incomplete lid closure, and a whole slew of other things, aside from, of course, the disfiguring type of look. Now, this, of course, can develop in non-AIDS patients as well, but again, your AIDS patients are going to be more at risk because they're immunocompromised. Okay, now moving on, our AIDS retinopathy. Our cause is kind of unclear with this condition. Usually, it does not indicate an infection of the retina. It's vascular and usually only happens when the CD4 count is below 200. Now, it's not usually sight threatening. Then what we're talking about is all these little white plaques back here that are starting to develop. It's not painful. It's going to have these little cotton wool spots. Again, like I just said, these little white looking plaquey kind of things. These are the cotton wool spots. They may have some microaneurysms. Remember, an aneurysm is just a ballooning of the blood vessel, if you will. So you may see some breakages in the walls of your vessels at the back of the eye. And of course, it can lead to hemorrhaging, both deep and superficial, if left untreated. So cotton wool spots have you seen in a healthy patient without underlying diabetes or hypertension, you should start to consider HIV testing. Excuse me. So again, remember, history is your biggest thing, but sometimes these patients aren't going to know that they have HIV or AIDS. They may not be aware of the conditions. They may not be able to verbalize it to you. They may know that they have things going on, but they may not know it's related to HIV and AIDS. So again, if you're starting to see these cotton wool spots in someone that doesn't have diabetes or high blood pressure, because of course those are more common to see those. But if they don't have those and you start to see these cotton wool spots and they have other symptoms that may be starting to line up, start considering HIV testing. Same thing like we said at the Kaposi sarcoma a few slides ago. If you start to see that nodular growth, that big purple violet growth, and they haven't told you that they have AIDS, they probably do. So start testing for it. Okay. Cytomegalovirus or CMV, so CMV retinitis. This is the most common opportunistic infection of the eye, and it's a leading cause of blindness in AIDS patients. That's something you guys should know. Most people contract CMV during childhood. They may have symptoms that are similar to mono, and they may maintain lifelong immunity if you keep the virus suppressed. I believe this was supposed to say 450, less than 450. Sorry about that. Prevalence of it is rising because AIDS patients are living longer, though, at lower CD4 counts. And of course, it can lead to keratitis retinitis. So, going a little more into our CMV retinitis, that's our pizza pie appearance. That's what you've heard. That's what you had in PD lab, PD lecture. You're looking for that pizza pie type of appearance. So, what is a pizza pie type of appearance? Because now we know that the pants is moving away from buzzwords. So they're not going to say you look on a fundus exam, you have a fundoscopic exam and it looks like a pizza pie. They're not going to say that. But they may say that when you look with the ophthalmoscope, you see necrotizing retinitis, multiple diffuse hemorrhages, frosted branch angiitis, which again is what we see in this picture down here. These frosted branches, they look like ice is on them. That's ischemia. So you're losing the blood flow to here. You're starting to have ischemia near where those blood vessels were. It's not going to have an effect on the pupils. Now, you may have black spots or floaters, development of blind spots. Again, that's because of all this going on here. Now, if we keep hemorrhaging into the back of the eye, those little blood spots are going to cause floaters because it's going to be blocking the light coming back to the retina. If you're having ischemia and dying parts of your retina, of course, you're going to start to develop blind spots. Usually, this isn't painful, though. Now, of course, it does increase our risk of retinal detachment by up to 33%. Treatment, we just want to slow the progression. We can do antiviral medications like acyclovir, foscarnet, cidofovir. We want to be a virostatic drug to stop the growth, but it can't eradicate it, but we do want to stop the growth. Now, of course, we can give that through IV or we can do it through an intravitreal implant. So we can do some type of injection or surgery into the back of the eye to try and help with this. Okay. Now, moving on, our toxoplasmosis retinitis, the most common non-viral intracranial infection. Parasite is coming from cat feces or raw or undercooked meat, and then it can, of course, travel throughout the body and reactivate in the eye and the brain. Your signs and symptoms, you're going to have white necrotizing retinitis with overlying vitreous inflammation, otherwise known as vitritis. Our buzzword for this is going to be our headlight in the fog, and that's something that you should know. There's not, if you ever see the headlight in the fog, that is, of course, our toxoplasmosis retinitis. And you can see here, it kind of does look like a car headlights coming at you on a real foggy night from far away. This may lead to severe floaters, blurry vision due to all the debris in the visual axis. And again, remember, your visual axis is anything from the cornea to the pupil to the retina. So anything in the way of that is going to block light and, of course, give us decreased vision. Now, you may see a red and painful anterior chamber, which we will cover at some point in our next lecture, is going to be called iritis. But iritis is not always needed to be there, but iritis is just exactly what this bullet is, a red and painful anterior chamber, a little bit of an inflammatory response. Of course, your toxoplasmosis can permanently affect the vision. Our treatment is going to be the pyrimethamine and sulfadiazine. Now, moving into a little more of our AIDS-related disorders, we have our orbital diseases like aspergillosis, which is again fungal. We have some optic nerve disorders that, like swelling of the optic nerve can be caused by toxoplasmosis or lymphoma. And of course, infection of the nerve itself could be from syphilis or cryptococcus. Dry eye is an inflammatory disease. Remember, I said earlier, dry eye is something that a lot of people don't know they have. They never even feel it. The eye doesn't feel dry, but that's because dry eye, as you continue to have it for days and weeks and months and years, the dry eye starts to damage the corneal nerves and you start to feel things less and less and less. And again, we'll get more into dry eye at a later time, but it is something to just, of course, note that dry eye is something that you always want to keep in your mind. Now, spontaneous corneal infections, whether it's fungal or herpes, you want to make sure all these kinds of things you're checking the brain. Acute vision change may be due to an intracranial process. So, moving on. These are going to be our bigger points. So I want you guys to make sure you're tuned in and listening. Your diabetes, your hypertensive retinopathy, these are the real big things for ophthalmology that you guys are going to see. And you guys are going to see this in clinic. You're going to see it on rotation. You're going to see it on your exams, like the EORs and the PANS, etc. These are your big, big things. And that's because so much of our population in the US have diabetes, have hypertension, they're obese, they're overweight, and all of these things are playing into each other. So, diabetes, hypertensive retinopathy, they're going to be your big, big topics. So, these are huge takeaways. I want you guys to really pay attention as we go through these. Just checking what slide we're on. 29. And again, remember, we're not cutting through all of this tonight. We will take a break and pick up on Thursday. So, diabetic retinopathy. This is a preventable cause of blindness. If you keep letting this go on and on and on, it's going to cause blindness. You want to be really early in your treatment of the diabetes. Make sure their A1C is low. We like to tell everyone in the clinic that we like their A1C to be below 7, but of course, the lower, the better. So, this is a leading cause of blindness among the working age population of the world. It's an inability to process the glucose that's causing our blood vessels to become damaged. So, the way that we like to usually explain it to the patients is that the glucose going through the vessels in your body, it's kind of like thumbtacks, if you will, going through a garden hose. Now, of course, most of the time it's not going to cause any damage, but here and there, the more thumbtacks that you push through the garden hose with the water, or again, sugar through the blood vessels, the more thumbtacks you're pushing through that garden hose, eventually they're going to poke holes and start to spring leaks everywhere. And that's where you're going to get your microvascular leakage, your capillary non-perfusion. Again, because we have leaks upstream, it's not going to get to the smallest capillaries. The final consequence is going to be visual impairment, damaging of the retina, and it also puts us at an increased risk for cataracts and glaucoma. And why is it the glaucoma? That's because of the neovascular glaucoma. So there's different types of glaucoma, but our neovascular glaucoma is when we're developing new blood vessels. And with extensive diabetic retinopathy, a lot of microvascular leakage and hemorrhages, we're not getting the proper blood flow around the eye. So you're going to start to develop new blood vessels all over the place to try and compensate, and it's going to crowd our angles. Remember we talked about the angles and the canal Schlemm last time, and uh, our vitreous, our aqueous humor kind of going through and pouring out through that trabecular meshwork. So if we have neovascular growth in that meshwork, that's going to decrease our outflow of fluid from the eye, increase the pressure, and lead to neovascular glaucoma. So again, diabetes could be leading to all types of things: cataracts, glaucoma, vision loss. That's why all of the primary care doctors that you'll be working with on your rotations always send their diabetics to get an eye exam at least once a year to check in on things, see how things are going. That's because the greatest thing about the eyes, and one of the things that I really like about my field, is that the eyes are the only spot in the body where we can see end organ damage from diabetes in real time. Now, of course, you're always going to want to send them to their kidney doctors. You want to send them to podiatry and check their feet and things like that. And that's all great because we always have to test for those things. But the eyes are the only place that we can physically see the damage from diabetes in real time. And that's one of the cool things that I like about this field. So when we look into the eye, we can see the blood vessels. And of course, if they start becoming damaged, we have neovascular changes, bleeding, hemorrhages, leakages. The eyes are an organ, so we're starting to see end organ damage in real time. And that's one of the cool things about the ophthalmology field. Now, of course, we don't want that for the patients, but it happens. And it's one of the cool things I can say that we do get to see and hopefully treat and prevent vision loss. Because again, diabetic retinopathy is one of our biggest causes of preventable blindness. 1 out of every 5 patients with newly diagnosed diabetes will also show signs of retinopathy on their exam. So, microvascular leakage. This is due to the development of microaneurysms that are eventually going to leak serum components or become thrombosed. So you're going to start leaking out of all your blood vessels over here. Now, for example, let's look at this leakage right here. If this continues to leak, we're going to just keep pumping blood out into the vitreous, which again, remember, this is all jelly back here, the vitreous. And if we keep pumping the blood just out through this leaking spot, all the vessel back here is not going to get the proper blood coming through it. So you're going to start to have neovascular growth elsewhere to try and help with that. So we may see some retinal edema with this microvascular leakage. We may see some lipid exudates, which we can see here, these big yellow honkers back here. That's lipid deposits. And of course, we can have our dot blot hemorrhages, which is more so what these are. Capillary non-perfusion. Of course, we're going to have our intraretinal microvascular abnormalities, cotton wool spots, neovascularization. So again, this is the cotton wool spot. This is our dot blots. This is our lipid exudates. And we'll go into a lot more pictures about the diabetes in a couple of slides. But this is something that you guys definitely need to know on your pants, your EORs, other tests. It's a huge point of eye clinic, but also regular clinic as well. Like I said, any type of clinic that you may be in, whether it's, working in a kidney practice, whether it's primary care, you're going to have these kinds of questions come up about the eyes. So again, we have more of our dot blots here. They're more circular, and a flame hemorrhage is more diffuse, kind of coming out looking like a fire. So that's a huge part of your tests. Remember, the dot blot, cotton wool spots, neovascularization, flame hemorrhages, those are all huge test points for the diabetes. So we have two types of diabetic retinopathy, our non-proliferative and our proliferative. The background mild, pre-proliferative diabetic retinopathy. So this is kind of before things are really getting severe. So you might have just a little bit of diabetic changes, but it's not really too crazy yet. Our proliferative diabetic retinopathy is when we have either a high risk or a non-high risk, and we can kind of determine between those. And we can also use something called a RET eval. It's an ERG. This is a new test that we actually just got in my clinic. It's kind of like an EKG for the heart, but it works at the back of the eye. And it also tests the pupillary response because as diabetics have a worsening and worsening diabetes profile, their pupillary response starts to become slowed, and the electrical signals that go across their retina, and of course the optic nerve and brain, start to become slowed as well. So this ERG is kind of like an EKG for the eye, and it detects our responses in the pupil and our cellular responses and electrical signals and tells us what risk factors we're looking at for our diabetics in the future. And it'll tell us if they're at, for example, 42% progression, 42% chance of progression in the next year to diabetic retinopathy. So then we can tell our patients, listen, You don't have any diabetic changes right now, but based on this test, you're at a 42% chance to start developing diabetic changes in the next year if you don't turn things around. Okay. So now we're going to start going into some pictures. I did put little snippets of what we're talking about in the bottom corners so that when you guys look at the things later, you're able to go back. But the big things I wanted to show you here, just some little dot blot hemorrhages. Again, this is early diabetic retinopathy. We might say this is non-proliferative because it's not going crazy yet. But again, it is our early stages. And these do look like some very little lipid deposits as well. But again, the big thing was kind of our dot blot hemorrhages. And when they're very small, like for example, over here, where my cursor is, that we might even just call like a microaneurysm. So there's different severities of how much bleeding is going on. You might call it a microaneurysm or a dot blot, or then of course, if it's more diffuse, a flame hemorrhage. It just depends how severe the bleeding is. Someone asked if it's the black dots. Yes, that's what we're talking about for this one, for the dot blots. So this is not as bright red of a picture. This is just depends on the machine and what machine's taking the picture. So you can see even our vessels here are a little more brown. So our dot plots are a little more brown slash black. But yes, these little dot areas that we're talking about all over the retina, this is our dot plots. Okay. Now, moving on, this is slide 35. Just check. Yep, 35. Just making sure I'm on track with my notes. So this is a fluorescein angiography. So we have a dye that can go into the eye to try and give us more of a better picture of what's going on back there. Now, this fluorescein angiography, the dye is showing us microaneurysms here, neovascularization, hemorrhage, ischemia. So I'll go through all of them with you. So all these little dots here, because this is a fluorescein picture, all these little dots, this is our dot plots here. And then our hemorrhages are starting to be more of these darker, big splotches here. The neovascularization, you can kind of see all over it. Usually there's not that much of these vessels in the back of the eye, at least not so prominently. Of course, there's capillaries all throughout the retina, but all of these extra little vessels, this is neovascularization because the eye again is not getting the proper blood flow, the proper nutrients, so it's making new blood vessel growth all over the eye to try and compensate. And we're also having some ischemia, which you can see over here where my cursor is moving in the bottom right. You can see this whole area is a little bit darker, a little less perfused, and you're starting to get ischemia. You can see a little bit of that up here next to the optic nerve, a little darker area. And then, of course, this is our area around our macula, also looking to get a little bit dark, so a little more ischemic as well. Okay, so moving on, number 36. This slide is again fundoscopic photo. This is showing us our lipid exudates, which are all these little yellow plaques all over the retina, and some mixed hemorrhages. Like I said, we have some microaneurysms, the really little ones, our dot blots, some flame hemorrhages. This one looks a little more flame-like, so maybe a little bit up here as well. So again, this is just showing a big mixed picture. This is more of a proliferative diabetic retinopathy photo. We have a lot of lipid exudates and of course mixed types of hemorrhages, dot blots, flame, microaneurysm. Okay. Now, slide 37. This is another proliferative diabetic retinopathy photo. And this is a pre-retinal hemorrhage. So this is at the back of the eye, but just before the actual retina layer, you can see that there's some separation of the layers there on the superficial layers of the retina, and there's a lot of blood pooling here. You can see it almost looks like a boat. It's like a cup, kind of. So all the fluid is pooling in this area and it's causing a mass effect in the back of the eye. It's causing decreased vision. Again, we call this a pre-retinal hemorrhage, but this is from proliferative diabetic retinopathy. Again, you can see up here some lipid exudates. You can see some dot blots, some flame hemorrhages. So there's a lot going on in the back of this person's eye. This is real proliferative diabetic retinopathy. Moving on, number 38. This is another fluorescein angiography. So again, we're using that dye to take a photo of the back of the eye. This is showing massive leakage of the blood. And that's these big hyperfluorescent areas, these bright white areas, even involving the optic nerve here. So you can see all this blood leakage all over the place. This is leading to a lot of non-perfusion downstream from those vessels. So you can see here this huge leakage of the fluid here of the dye, leading to all this non-perfusion afterwards, which is leading to ischemia. That's why all these areas are so dark. They're starting to become ischemic, starting to get damaged and die. Someone asked if we're going to be putting retinal pictures on the exam. No, we're not going to be putting photos on the exam. The exam is all verbal, not verbal. It's all words and vignettes like you've been seeing this semester so far. So there's not photos on this, but it is something for you guys to know and understand. I'm trying to just show you with these different pictures all the things that diabetes can lead to in your patients. And again, the more and more they let their diabetes go out of control, this more severe the eye symptoms get. And of course, the more damage they can have in the eye. Someone asked me if we get their diabetes under control, can these issues improve or is it permanent? And the answer is it depends. So we can pump the brakes if we get it under control. There are a lot of new injections called anti-VEGF injections that our retina specialists often inject into the back of the eye that can help prevent future leakages, help slow down the leakages. They can also do what's called a PRP laser, and they can start lasering the back of the eye and singeing the spots of the retina that are leaking the blood. But those lasers cause visual impairment. So it may stop further diabetic damage, but each laser spot causes a little mini blind spot. And eventually you're going to have vision loss from those lasers. And if you keep going untreated, of course, your vision will continue to worsen. And again, it just depends how severe the diabetes was when you intervene. So, for example, if I go back, to this kind of pre-retinal hemorrhage here, this is going to probably cause some lasting deficit. You're going to have some blind spots from this. You're going to have blood that's in the way of the visual axis. And the more that diabetes keeps going, you could even lead to things like retinal detachments. So it just depends how early you intervene. If you intervene early and it's just some dot blot hemorrhages, some flame hemorrhages, you're probably not going to have long-term visual effects. But if you start to have ischemia, non-perfusion, retinal detachment, scarring, that's when it's starting to become more permanent. So to answer your question in a simple one sentence, it just depends how soon you intervene with the diabetes, and that's going to determine if the issues are permanent or may improve. Okay. Now, moving on here, this is a proliferative diabetic retinopathy photo again. This is showing us some scarring, which we see all throughout here. See these kind of brighter yellow areas. They're folding, they have tractional tendencies to them. So this tractional folding areas, the brighter yellow, that's all scarring. And that's from, of course, all the leakages of the blood. It's trying to reabsorb. It's creating kind of a scar tissue. Of course, we have a lot of blood leakage here, a lot of flame hemorrhage, a lot of blood being lost. And again, that's going to add more and more and more to this scar tissue, the traction, and then, of course, lead to like a retinal detachment, which we see more so here at the inferior spot. When it looks kind of out of focus, that's the retina more so coming up at you. So that means there's starting a retinal detachment down in the bottom area. You also have a lot of vascular tortuosity back here as well. So that means the vessels just aren't moving the blood along very well. Now, this is these little black spots here in the back of the retina. This is that PRP laser that I had mentioned to you guys, that laser treatment. So everywhere that this doctor was seeing someone have a little dot blot hemorrhage, a little microaneurysm, they singed it with a little laser spot. But again, this is pretty proliferative here. So each of these little black laser spots is a little blind spot. Now, the brain does its best to fill in gaps and fill in blind spots. But if you keep getting more and more lasers all throughout the retina, there's a lot of blind spots that the brain doesn't know what to fill in, and you're going to really start to have a lot of visual loss. Of course, you have some residual hemorrhage here, so they may have continued treating with laser for this patient. And of course, you have some tractional scar tissue again, which remember is this kind of brighter yellowy green area. Looks like it's folded, thickened up. That's our tractional scar tissue, and this could lead to a retinal detachment as well. Someone asked, at what point is it not beneficial to do the laser treatment if it results in so many blind spots? And unfortunately, the answer again is it just depends. So it depends how severe their diabetes is. I'll go back to that photo. Depends how severe their diabetes is, how much vascular leakage there is, how quickly it's turning into scar tissue. A lot of times, the doctors don't want to overdo it on lasers. But again, it's a give and take. So, they have to try and weigh the pros and cons and also talk about it with the patient as well of do we want to keep lasering the retina, causing these little mini blind spots, causing a decrease in vision, or do we want to let it keep leaking and keep making scar tissue and keep pulling on the retina and causing risk for retinal detachment? So again, it's just an answer of it depends. It's just something that you'll find clinically if you ever go into eyes, which I do recommend. It's a great field. But if you go into eyes and you start working in the retina more, you'll start to get a feel for how things are progressing, how quickly your patients are progressing, and what's the benefit risk ratio for them. So unfortunately, I don't have a specific answer of when they stop. Again, it just depends. It depends how the patient looks, how they're feeling, how their vision is, and what our future outlook is for the patient, and if they're going to get their diabetes under control or not. Now, remember, like I had mentioned before, one of our new treatments is called anti-VEGF. It's an injectable medication that does help prevent some of these vascular leakages. And they're starting to go more towards the anti-VEGF treatments as their first line as compared to the PRP laser. The PRP laser was our first line for a long time. But now that we have an injectable medicine that is more of our first line, I'm just showing you what you probably will see if you're ever looking with the ophthalmoscope or on a fundus photo. These are all things that you're probably going to see. So now we're getting into some abnormal OCT changes. So OCT stands for optical coherence tomography. This is what we would call diabetic macular edema. So our macula, we want to have a nice curve to it, a nice dip. And I don't have a photo though. Let me show you what our normal looks like. Can you guys still see my screen? If you can, see this normal dip here? This is a normal Mac OCT scan. So this is your macula. This is your fovea
We
right at
just
that
see the
central dip.
slides.
What was that?
We only see the slides. I don't know if that's
Oh,
what you're referring to, but
let me pull it up. Hold on. Thank you for telling me. All right, now you should be able to see it. Do you see it now? I'm on Google.
yeah. Thank you.
Okay, so this black one here, this is like a normal Mac OCT scan. So this little dip here, this is your fovea right at the center. This whole thing is the macula, but this is what we want it to look like. Again, here's just the color version. This is what we really want to see. Okay. So that nice normal little dip and curve, nice uniform layers. Now going back to our slideshow, you can see that, of course, now this is quite a stark difference to the one that I just showed you on Google. This is quite abnormal now. You can see the difference. So this, in this case here, when we're talking about diabetes, this is called diabetic macular edema. Now, there is another condition called cystic macular edema that looks the exact same. Both of them are cystic changes. It just depends on the etiology. The etiology depends on what we call it. So if it's from diabetes, then we would call it diabetic edema. If it's, for example, a post-op patient, someone who just had surgery, those are the people that we call more so cystic macular edema, so CME versus DME. Again, just depends on the cause. But same thing, it's the same thing in the back of the eye. It's just big cystic fluid bubbles in that macula pushing up on that tissue. Now, remember, the macula is where you get your 20/20 vision from. So you can imagine that if you have all this swelling and all this fluid in the back of the eye, instead of a normal tissue layer, your central vision is going to be severely impacted, and it's going to lead to decreased vision, blurry vision, fuzzy vision, loss of vision. And if this persists, again, could cause permanent vision loss in the future if left untreated. So this is just another showing you of the diabetic macular edema on our OCT machine. And it's all due to that fluid swelling up in the retina, distorting the vision. So moving on, this one's just showing us a lot of lipid deposits, hard exudates. That's kind of the more strong borders, the more defined borders is our hard exudates. And of course, we have some bleeding around here as well, some dot blots and some flame hemorrhages. You can also see a little bit of kind of cotton wool forming around the optic nerve. Now, this is another fluorescein. So your fluoresceins are always going to be your black and white ones with the dyes, just so you're aware for future. If you ever see them while you're out practicing, your fluorescein ones are going to be your dye scans. So this one has some macular edema. So our optic nerve is over here. If you could follow my cursor, optic nerve is over here. Our macula is kind of here in the center, and we have a lot of macular edema, a lot of leakage, changes in the retinal pigmented epithelium, which is our darker areas here. And when you have changes in the RPE, the retinal pigmented endothelium, that means you have cell death. So we have a lot of swelling, leakage, and cell death in the macula, which means that, of course, we're going to have central vision changes and loss of the vision. So moving forward with diabetes. This is a dense topic. This is really important for all areas of medicine, usually diabetes, but especially in ophthalmology. So proliferative diabetic retinopathy carries the greatest risk of visual loss due to that ischemia that we talked about. Remember, if you're losing all of your blood, it's not going through the blood vessels to the right areas and perfusing the tissue. You're going to have ischemia and necrosis and death of the tissue. Our proliferative diabetic retinopathy is characterized by neovascularization on or adjacent to the optic nerve. So again, remember a few slides ago, I showed you all those extra blood vessels. That's our neovascularization. That's what's causing us to go from non-proliferative to proliferative in our classification. You may see a lot of hemorrhages in the vitreous. And of course, those hemorrhages can cause acute vision loss by blocking light from hitting the retina. You may have macular edema. And of course, you're going to have more permanent complications, such as retinal detachments from that scar tissue, that pulling force, and of course, neovascular glaucoma, which we touched on a little bit earlier, that new blood vessel growth going into the trabecular meshwork, blocking our outflow of fluid from the eye, increasing the eye pressure, causing glaucomatous changes. So all of these things here are neovascularization, are diffuse hemorrhages, macular edema. That's all going to be when we start to classify it as proliferative diabetic retinopathy. So, our signs and symptoms of our proliferative diabetic retinopathy, they have maybe sudden loss of vision. It could be gradual loss of vision. Again, it just depends how fast the diabetic changes have come on. Laser surgery, we can burn those little areas with the PRP laser, like I said earlier. That's pan-retinal photocoagulation. It helps seal the retina. We can do observation or vitrectomy. And remember, I also said that we can do anti-VEGF treatments as well. So that's something I want you to just add to this slide. I didn't have it in the notes, I'm sorry. But if you could add to this slide the anti-VEGF treatments, also something that could be done. And that's more so what they're moving towards for our first line at this point. So, tractional retinal detachment that occurs when the fibrous membranes or the scarring that we talked about, remember those kind of folded lines, the kind of thickening of the tissue there, so you can see it all through here. That scarring membrane has a tensile strength and starts to pull the retina, and it starts to pull the retina away and eventually detach it. So that mechanical traction force pulls it away from the RPE. Usually it's painless, but it does cause loss of vision. So it's more common in the advanced stages of proliferative diabetic retinopathy. And this is the second most common type of retinal detachment after the rhegmatogenous type. Now, see up here in this photo, this up here, this out of focus area of the photo, that's our detachment. Remember, that's out of focus because the photo is focusing on the retina, but if the retina is pulling up towards the camera, it's out of focus compared to the rest of it. And that's what you're seeing here is that kind of billowing of the tissue towards the camera, towards the viewer, or towards your eye, for example, if you were using a lens with a slit lamp exam to see the back of the eye. So whether it's you seeing it clinically firsthand or if it's a photo, again, that kind of more out of focus area, that's your detachment. And that needs to be addressed immediately. Neovascular glaucoma. Remember, we already briefly talked about this. Your diabetics are twice as likely to develop this, and most commonly occurs with our proliferative diabetic retinopathy because you're growing blood vessels all over the place. Remember, like we talked about last lecture, there's not going to be blood vessels usually across the cornea. But you can see these photos, you are having some across the cornea, and you're also going to have some more so on the iris, which you see more so over here as well. So it's going to be growing over the iris, which is a muscle. You may have it growing across the cornea. And of course, you're going to have it growing in the trabecular meshwork as well, which is more so over here where my cursor is, kind of growing into that little trabecular meshwork area. So iris neovascularization can block the drainage of fluid from the eye. Our first line treatment is multifactorial. Again, anti-VEGF injections to slow our changes, followed by PRP laser or pressure lowering eye drops. We could also do laser cytophotocoagulation, which just means that we're going to use a laser to obliterate part of the ciliary body. Remember, the ciliary body is where we're producing our fluid for the anterior chamber. Okay. Retinal disease and hypertension. So arterial sclerosis, it's a thickening of the retinal arterial wall. You're going to have light reflex changes. That's where you get your copper wiring, your silver wiring. Silver is much worse. That's more severe. That's from profound high blood pressure for a long time. So, important pants point that I want you guys to know, or for the EORs, other things in clinic, your hypertensive retinopathy, the biggest thing is going to be your AV nicking, your arteriolar attenuation. And remember, like we just said, silver wiring is more severe than copper wiring because that comes from more chronic hypertension. That's more of a thickening of the vessels. So the artery is much smaller in caliber than our vein usually. Our AV ratio, so artery to vein ratio should be about 2 to 3. So AV crossing changes. This is where we get our AV nicking. The larger arterioles cause compression of the veins underneath. This is our normal crossing. You can see that all the blood vessels have their normal shape. Picture B, you can see that the vessel underneath is kind of being choked out, if you will, because there's so much pressure in the artery, it's choking out the vein underneath it. So severe AV nicking can lead to retinal vein occlusions. You may see some diffuse hemorrhages, cotton wool spots, and of course, loss of vision if left alone and not treated. And you have those big retinal vein occlusions, like a branched retinal vein occlusion or a central retinal vein occlusion, etc. So hypertensive retinopathy, we have a very big case of hypertensive retinopathy here. All the blood vessels starting to pop and burst and leak. Now, macular degeneration. So remember, our macula is our center spot of vision, our 20/20 spot. So macular degeneration is a disease that is progressive. It's going to continue to destroy the macula and the tissue within the central portion of the retina. Again, that's our macula, giving us our central vision. So when you're looking at the screen right now, all the light is landing on your macula. There's two types of macular degeneration. You may have heard this in clinic, in your other classes. You may have heard it with families or friends. You have wet macular degeneration, which is more advanced. That's more leakage and blood loss and more change. And you have your dry type that can always advance to wet. Macular degeneration is one of the leading causes of blindness in the elderly. So ARMD, age-related macular degeneration. Okay, quick anatomy look at the macula. So you have your Bruch's membrane. That's our innermost layer of the choroid, extending from the optic disc to the anterior peripheral retina. Defects in this membrane can be seen with macular degeneration. So, of course, we have our little diagram over here. The function is, of course, it's our support structure, our blood retinal barrier. The RPE, remember, that's our retinal pigmented epithelium. That transports waste from the photoreceptors across Bruch's membrane to the choroid. Now, remember, like I said earlier, changes in the RPE mean that there's starting to be cell death because the RPE, the retinal pigmented epithelium, that's our transporter of waste. So if those cells start to die, it's like if you were walking with a garbage can, for example, and you dropped all the garbage everywhere. That's exactly what's happening when you're seeing RPE changes. Those cells are dying, they're dropping that waste, and it's showing you death of cells in that area because that waste and that pigment is all clumping together. Okay, of course, it's going to get thicker as we age, and that's going to impede the transport of waste material. Buildup and deposits of this are called drusen. Drusen is our first sign that we're going to see of macular degeneration. So if you were ever asked that or pimped on that question in your rotations, your first sign of macular degeneration is going to be drusen. That's your first clinical sign. This is just another little diagram that you can, of course, read into a little more if you would like to later, if you are interested in more of the anatomy of this. But again, remember, we're not going to be showing you pictures on the exam. Drusen bodies. So this is different from the lipid deposits earlier because the lipid deposits are more superficial, so they're closer to you in these pictures. The drusen bodies are more so in the body of the retina, in that tissue. That's these little yellowy plaques back here. But again, you just have to be looking at enough of them to determine if it's really like a lipid deposit or is this a drusen. So the drusen is made up of lipids and fatty proteins. They can be soft or hard. And it looks like we have a little bit of a mix of here. So this is more so like a softer one. This is more of a harder one. So you could see that based on the difference in their borders, their coloring. And of course, if you were looking clinically, you have a little more 3D view of it, and you could see that as well. And that helps make your determination. Your harder ones are going to have more of a 3D look to them. because they're a little more built up. So macular degeneration, again, dry. That's our most common type, 85%. Our risk factors is going to be age greater than 60 years, your family history. But one of the biggest things is smoking, 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 smoking. So if your patients are smokers, you need to tell them that is the biggest risk factor for developing macular degeneration. They need to stop smoking if they want to keep their central vision. Of course, hypertension, obesity, cholesterol, that all adds to it, but smoking is your real big factor here. Of course, you have familial genetic components. Caucasians are more likely to get this than African Americans. Females are more likely to get it than males. Like I said on the last slide, our first sign of macular degeneration is going to be drusen. They eventually destroy the photoreceptors and macula, and they slowly deteriorate, resulting in blurring or spotty loss of the central vision. Wet macular degeneration, this is our neovascular type. It occurs behind the macula as the RPE and photoreceptor cells die. Remember that RPE clumping, the drusen causes all of that and the death of those cells. So as they continue to die, you're going to start to have neovascularization in that area to try and alleviate the symptoms of not moving that waste. The vessels develop where the Bruch's membrane begins to break down, usually near the drusen deposits. The vessels are very fragile and they start to leak blood, resulting in scarring. Remember that scar tissue in the back of the eye has a tensile strength, can cause retinal detachments. And of course, the buildup of that scar tissue is going to distort the shape of the macula. And like I showed you with the OCT earlier, the distortion of the shape of the macula is what is going to start to cause changes in the vision. So the result of the wet macular degeneration, you're going to have distorted vision or a loss of vision. 90% of these cases are what we call legal blindness. So the legal blindness, 90% of them is because of macular degeneration. All wet macular degeneration is considered advanced. Your signs and symptoms, you have blurred vision, central scotoma. Scotoma just means loss of vision, a blind spot. Scotoma is a blind spot. So this is what someone's seeing with macular degeneration when it's very advanced. That whole central macula area is dead. It's distorted. It's broken down. So you're not getting any light landing there that's turning into the electrical impulses and going to the brain. The light's hitting, but it's not doing anything because all those RPE cells are dead. So it's not doing anything to give you vision in that whole central area. This is more of an early sign down here. So that distorted vision, the metamorphopsia, grid of straight lines may appear wavy. And we'll get into that in a second. They may have trouble discerning colors, acute vision loss if the retina detaches. Remember, as we continue having swelling, hemorrhage, leakage of the blood, pushing up on the retina, tensile scar tissue, that all increases our chance of retinal detachment and vision loss. So, macular degeneration. One of the things that we always wanted to look at is our Amsler grid. If you're suspecting that they may have macular degeneration, they have a lot of risk factors, a lot of family history, then you want to give them one of these Amsler grids. It's just a straight up and down and crossed hatch lines, and they're going to put this on like their fridge, something like that. Look at it kind of once a week. It should look like this, just all nice squared lines, squared boxes. If they start to have macular degeneration and that metamorphopsia, like we talked in the last slide, they're going to start to see some distortion or some loss or some darkening in that. And if they start to see changes, that's when we start to investigate a little more into the macular degeneration. So early dry ARMD requires no treatment, but of course you want to keep monitoring for any changes to wet. No one has found a treatment for or a cure for the dry form, but one of the best things that we have at this point is our antioxidant eye vitamins. The biggest name in this is called AREDS. So it's Preservision. AREDS is the company and the product. The AREDS is just an antioxidant eye vitamin that helps pump the brakes if you will, helps slow down the macular degeneration. Now, the studies only say that it works for moderate to severe macular degeneration. However, at our clinic, we just tell everyone as soon as they start to have the early signs of it, they might as well start using it. It's a twice daily vitamin. Those antioxidant properties help prevent the RPE changes, the cell death, and the change of the structure. Again, the studies only say that moderate to severe macular degeneration is helped by using these vitamins, but if it were me, I would just start using it anyway. Now, our most current formula, and they just came out with this a couple of months ago, is our A-Reds 3. So this is our third generation of the A-Reds. A-Reds 3 is our most current, but because it just came out, A-Reds 2 is still probably your most prominent that you may be seeing people use. Now, we did have a case in our clinic of the A-Reds 2 causing paresthesias. And that's because of too much zinc. And that's one of the things that they changed between the A-Reds 2 and the A-Reds 3. Now, just a little bit of background knowledge, the company, the Preservision company, they were never sued for something like this, and they never publicly came out and said anything about these paresthesias, this myelopathy. But the biggest change that they made between the AREDS 2 and the AREDS 3 was decreasing the amount of zinc. So I don't know if they were starting to hear about studies of it or what the case was, but one of the biggest changes was giving less zinc in the AREDS 3 because that AREDS 2 having too much zinc leads to a copper deficiency, myelopathy, and paresthesias. So if you're in the clinic or if you're in the ER and you have someone coming in for some unknown cause of gait disturbance, sensory ataxia, paresthesias, and you don't know what's going on, again, history, 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 find out what meds they're using. They may not even tell you about the AREDS vitamins because they're just over the counter. So they may think it's unimportant. But again, make sure you're always asking them even about their supplements and their vitamins because this AREDS 2, there have been a few cases, and we saw one in our clinic of that copper deficiency myelopathy, and that was caused by using too much of those AREDS pills. So again, history is a huge factor. I can't stress that to you guys enough. But that's something to keep in mind that even if you're not in ophthalmology, you can start to see some of these myelopathies, and it could be related to ophthalmology and the antioxidant eye vitamins that they're using. And again, this Ambler grid, we already went over this. This is close monitoring. The patients can test this themselves at home. Treatment, anti-VEGF. Again, anti-VEGF is one of our newest treatments in ophthalmology. They're starting to use it more and more prominently, more first-line treatments at the back of the eyes, diabetic retinopathy, macular degeneration. It's a really good treatment. It's kind of a biologic, if you will, that starts to help with those leakages and the blood vessel growth that's abnormal, helps prevent those kinds of things. We could do photocoagulation. Again, that's the laser. It burns the areas of the retinas and the blood vessels beneath, but it does leave scarring and of course, blind spots. PDP, this is used only in wet, injecting a small chemical into the blood that reacts to specific wavelengths of light, creating blood clots and blocking the abnormal blood vessels. So you use this little chemical and then the certain laser going through the eye, and they'll react at the back of the eye, causing little blood clots and starting to stop that leakage of the blood in the back of the eye. Avastatin, Lucentis, Eylea, those are antivascular endothelial growth factor drug that's injected to the eye. So again, that's the anti-VEGF, which we talked about up top. Okay, we're just going to go through quickly a couple more slides and we will stop around the mid 70s. So real quick through the next couple slides. Okay. Now remember with the macular degeneration that we just finished, there's not really a cure for that. We can only pump the brakes with those antioxidant eye vitamins like the AREDs or the anti-VEGF or even the laser therapies. It's not a cure, it's pumping the brakes. So pupil problems, Horner's, 80s, and Argyll Robertson. So does anyone know what this is called? Sorry, you don't have to mute. This is called anisocoria. Good. These two people did answer me. Thank you, Noel and Anne. So anisocoria in the two pupils. So we are coming up now to Horner's syndrome. Now, I want you guys to remember before we even go to this slide, Horner's syndrome is not a disease. It's a clue to something else. So if it's a first order neuron, which we'll get into the first order, second orders, if it's a first order neuron, it's something breaking the signal track down the brain and spinal cord. If it's a second order, it's a lung tumor, maybe a mass effect. If it's third order, it may be an artery dissection. So if you see a small pupil, droopy lid, you need to find the break in the chain somewhere, whether it's first, second, third order. So you want to check the brain, the lungs, the carotid artery, whichever may correlate to finding a stroke or a tumor or some type of tearing artery. Okay. So again, Horner syndrome is an interruption of the sympathetic pathway, which I just said. You're going to have meiosis, you're going to have ptosis. So ipsilateral meiosis, ipsilateral ptosis, and anhidrosis. So that's our PAM. That's a big thing to remember. Something to always look for Horner's. Ipsilateral ptosis, meiosis, anhidrosis. So first order neuron, like I said, could be stroke, tumor, some type of break in that pathway. Second order could be surgery, trauma, aortic dissection, carotid dissection, tuberculosis. Again, that's your tumors, your mass effects. Pancoast tumor, especially if it's arm pain being present, maybe it's a neuroblastoma. Again, Horner's is not a disease itself. It's just giving you a clue that something else is going on. So your big takeaway here is your PAM. I just want you guys to remember that. If you're seeing your ipsilateral meiosis, ptosis, and the anhidrosis, start looking for things that may be going on for causing that Horner's syndrome. Okay, so again, this is just showing you our pathways. The first order neuron is the black, second order is the solid red track, and the third order is our dashed red track. So classic findings for Horner's, again, our PAM, uh, anisocoria, which we saw in that picture earlier. You're going to have your constricted pupil, the meiosis. You're going to have ipsilateral ptosis, which is the drooping of the eyelid, and the ipsilateral facial anhidrosis. So again, you're not producing that water or the sweat. So just remember your Horner syndrome, it's not a disease itself, it's a clue to something else. So if you see someone with a small pupil, a droopy eyelid, find the break in that chain. Find what's causing that Horner's syndrome. You may have some heterochromia of the iris. Usually, if the trauma occurs less than 2 years old, you may have a lighter color in that affected eye. Eyelid retraction, low eye pressure, change in the tear film. Refer to a neurologist and an ophthalmologist to kind of investigate a little bit more. But again, your Horner syndrome is not a disease itself, but it's going to give you a clue to something else. So you should get your testing, like your MRIs, your CT scans, your X-rays, to try and find the site of the lesion. You could do what's called the cocaine test. Cocaine's a major dilator. So if there's no change after the eye drop administration, this is when we say this is definitely true Horner's syndrome. Again, that's the change in the eye colors, and of course, the change in the pupil sizes, that meiosis. 80s tonic pupil is a dysfunction of the autonomic nervous system, the parasympathetic system, characterized by one pupil being larger or dilated, so mydriatic, a sluggish response to light. Homie's 80 syndrome is the loss of our DTR, or Ross's syndrome is when it's paired with the anhidrosis. 80s tonic pupil is benign in nature, seen more commonly in females. The etiology is unknown, though. We think it's related to an inflammation or infection at some point in the life that damages the neurons and the ciliary ganglion, but again, a little bit unknown. It's not proven. Treatment for this, pilocarpine, just for cosmetic purposes. Ophthalmology can also investigate a little bit further if you want them to. Again, just seeing the differences here, we're going to have a sluggish pupillary response, and of course, the differences in the pupil sizes. Argyll-Robertson pupil, aka the prostitute's pupil. It's a rare syndrome that occurs in patients with tertiary syphilis because the CNS involvement. They're going to have light near dissociation, loss of response to light, but maintains the near reaction. So they're going to have constriction, convergence, accommodation. So over time, both pupils become smaller, like less than 2 millimeters, and irregular in shape. So our big thing with the Argyll-Robertson pupil is it's going to accommodate, but it doesn't react. So that means it's going to get smaller or change in shape when you shine light on the other eye, but not on the direct eye. So if you remember, I'm sure you went to this in PD lab, when you shine the light at a pupil, both of them should be reacting the same. So that's why you want to check one pupil, look at that direct pupil that you're shining the light on, and also look at the other pupil. When they have the Argyll-Robertson pupil, you shine a light on it, it's not going to change. You shine a light on the other one, it'll start to change because it's interacting just based on what the other one is doing. So it's going to accommodate to the light, but not react to the light. Initially unilateral, but eventually becomes bilateral. They may have normal vision, though, despite this pupillary change. So ARP, Argyll-Robertson pupil, accommodation reflex present, pupillary reflex absent. So eye movement disorders. Just go through these very quick. So it's due to abnormalities in the brain, the cranial nerves, neuromuscular junctions, or the musculature. So you have your optokinetic reflex. You can follow an object in motion that's occurring at 6 months old. Now, I'm not going to click these videos. These are more so just for you guys. There's a couple more videos on the next couple of slides. That's just if you want to look more into what we're talking about. But again, not necessary. You're not going to have photos and videos on the test. It's just things for you to understand these eye movements. Okay. Saccade is our fast conjugate movement of the eye, like reading. So that's when your eye is kind of jumping, 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 and it's not a smooth look. It's not a smooth gaze movement. It's when you're jump, 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 and kind of fast movement of the eye. Vergent eye movements is when you have disconjugate directions when moving towards or away. And again, you have videos of all of these that you can look at. Nystagmus, involuntary, rapid, repetitive movement of the eyes, may be seen at the extreme points of gaze, an abnormal function in the cerebro, I'm sorry, I lost my words, cerebrovestibular, optokinetic, and pursuit systems. And you have a YouTube video here that goes a little more in depth with it. But again, this can be caused by medications, excessive alcohol, head injury, Meniere's disease, labyrinthitis, stroke, thiamine and vitamin B12 deficiency. It could even be due to things like previous eye surgery, for example. Now, I personally do have a little bit of a nystagmus as well, and mine's from a previous eye surgery. I used to have what's called strabismus, and we'll get into that. But strabismus is when your eye muscles are not quite lined up. So I used to look like this. If you see me on the camera, I used to look a little more rightwards to be looking straight. They cut my eye muscles and nerves, reattach them, so now I could look straight. That was when I was very, very young. But now when I look all the way to the side, I have a little bit of an nystagmus. So again, there's a lot of things that can cause it. And just when you see that nystagmus, that involuntary repetitive movement of the eyes, the jumping, it makes you want to look into things more. You know, if you're in a detox wing in the hospital in the ER, could be from medications or alcohol. If they've been in a car accident, of course, you're going to be thinking more so a head injury. So again, just looking at what the patient presents with and saying, okay, we need to dive a little more in depth into their condition, maybe get some more testing, see what's going on. So types of nystagmus, it's going to be based on the direction. They're going to be horizontal, vertical, rotary. And of course, there is videos that you can look up of this type of movement, the jerk or end gaze. It's a slow drift of the eyes away from what you're looking at and then rapidly correct back to the point of fixation. This is your most common form, your jerk end gaze nystagmus. There's a pendular nystagmus that could be torsional, horizontal, vertical, or a combination, kind of going all around. This could be congenital, it could be acquired. Remember, they could be born like this, it could be from an injury, it could be from drugs or alcohol. The latent nystagmus happens only when you occlude one eye, or manifest is when it's present all of the time. So mine, for example, is more so a manifest. It doesn't happen until I look all the way at the end point of my gaze. So mine's more of the jerk end gaze form. Often this is associated with vertigo. They may develop a compensatory head movement. So Alexander's law is when a jerk nystagmus becomes worse when looking in the direction of your saccade component. So remember the saccade is those jerking eye motions. The Alexander's law says when you're looking in the direction of that saccade, the jerk nystagmus gets worse. Treatment, removal of the cause. So again, there's a whole bunch of causes. Could be drugs, could be alcohol, could be brain trauma, etc. So if you fix the cause, you should fix the nystagmus. Reduced vision may be improved with glasses or contacts. The contacts sometimes are a little bit easier for these types of patients because the contacts are going to move with the eye. As you move back and forth, move the eye side to side, the contacts are staying right in the center of your cornea. They may need things, something like a prism, for example, which is kind of a triangular glass that distorts the image instead of being straight on. It angles the image for someone who has the eyes looking in different directions. Prisms are, of course, great for that, or eye muscle surgery, like I said, I had when I was much younger. You can also do Botox toxin injections to temporarily get rid of that nystagmus by paralyzing that muscle. Eye movements in comatose versus brain dead patients. So they have the VOR, vestibulo-ocular reflex, stabilizes images on the retina during head movements by producing the eye movement in the direction opposite to the head movement. So doll's eyes, for example. So we're going to be looking here, we're testing that ocular reflex, testing the doll eyes. Normal is if you're putting in the cold liquid into the ear, your eyes are going to roll over to that side. Abnormal, so of course it's going to be your brain dead patients. The eyes are not going to deviate away. So that's our caloric stimulation induced nystagmus with ear irrigation. So we're always checking this to make sure that the patients are either comatose or brain dead. Just another test that we can do. Neurologic eye disorders, we have our nerve palsies, Bell's palsies, cranial nerve palsies. But this is where we're going to stop for today. So we're going to come back on slide 78 for Thursday. Does anybody have any questions? Did I go too fast at any point? Did I lose anyone at any point? Or is everything clear? Okay, well, that's it for tonight. I'll hang out for another second if anyone has any questions. Remember, we'll pick back up on page 78 next time, but I'm here for any questions, or you could also, of course, always email me any questions that you may have.